Welcome everyone to our 35th CAPE Community of Practice event. My name is Amanda and I will be introducing today's session and moderating the Q&A afterwards. The topic of today's webinar is Can Alcohol Policy Prevent Cancer? Modeling the Impacts of Alcohol Policies on Cancer Mortality and Incidence Research Findings. Please note the views and opinions expressed as part of this presentation are those of the presenters and do not necessarily represent those of our funders or other organizations acknowledged. Up is Dr. Adam Shirk. He is a senior scientist with the Canadian Centre on Substance Use and Addiction and a scientist with CSER and an author of Canada's Guidance on Alcohol and Health. His research focuses on health economics, alcohol caused health harms, the link between alcohol and cancer, and population-level substance use policy. Adam is lead author of the International Model of Alcohol Harms and Policies, or InterMAHP, which has been used in Japan, New Zealand, Switzerland, Finland, Colombia, and other countries to estimate alcohol-related harms. And Keegan Lawrence is a research associate at CSER. His master's research was in health economics and machine learning. His research now focuses on alcohol surveillance, alcohol-caused harms, and the link between alcohol and cancer. So I will pass it off to Adam and Keegan.
Today, Keegan and I will present about Can Alcohol Policy Prevent Cancer? And we'll be looking at a modeling study where we estimated the potential health impact of two different alcohol policy strategies in particular, the first being minimum unit pricing and the second being alcohol container labeling or beverage labeling. I will look at the potential impact of those different alcohol policies on cancer incidence and mortality. Yeah, Keegan and I will be presenting. Also a shout out to our other authors who are Dr. James Clay and Dr. Tim Stockwell. Then I'll pass it over to Keegan and we'll each do half the presentation.
Great, thanks, Adam. Before we begin, I just want to acknowledge that we're presenting this work from the traditional territories of the Lekwungen, Songhees, and Esquimalt peoples, on whose the territory the university stands, and the Lekwungen, Saanich peoples whose historical relationships with these lands continue today. And then before I dive into it, I want to acknowledge also the support that made this project possible. This work was funded through a grant from the CIHR and the Canadian Cancer Society. And we also want to thank some of the stakeholders mentioned here and collaborators who were involved in this project, including some of these teams from Health Canada, Public Health Agency of Canada, Canadian Partnership Against Cancer, the BC Ministry of Health, Public Health Ontario, and the Centre for Addiction and Mental Health. And yeah, as Adam mentioned, here are some of the authors affiliated with the art, like the paper side of this project. Here's a quick overview of where we're headed today. So we'll start with some background on how alcohol is a cancer risk factor and the broader burden alcohol contributes to cancer in Canada. Then I'll walk through some of the data sources that we employed in our study, including cancer registry data and alcohol consumption data, followed by a summary of our modeling methods. From there, we'll explore the 5 policy scenarios that we tested that Adam briefly mentioned there, and what the model projected in terms of changes to alcohol use and cancer incidence and mortality that these policies could impact. And then we'll look at the results overall and break them down by cancer type and sex and province and territory and by socioeconomic position. Then we'll close with a few reflections on why equity matters in this space and what these findings could mean for policy and practice. So beginning, why is cancer an alcohol risk factor? Or sorry, why is alcohol a cancer risk factor? So alcohol is a group 1 carcinogen, which puts it in the same category as asbestos and tobacco. Evidence has shown it's linked to at least 7 major cancer sites, from liver cancer to breast cancer. I'll discuss more particularly what those cancers are in the next slide. So alcohol can increase cancer risk in a few different ways. First, when we drink alcohol, our bodies break it down into acetaldehyde, which is a toxic compound that can directly damage your DNA. It can create oxidative stress, which basically means when your cells are exposed to these unstable molecules that can cause long-term harm, like DNA injury. On top of that, alcohol also affects hormones and can raise like estrogen levels, which help explain some of the link to breast cancer. And over time, heavy or frequent alcohol use weakens the immune system and creates chronic inflammation, which makes it easier for cancer to grow. And the risk with both how much and how long you drink. Um, and yeah, zooming out a little bit. So alcohol is responsible for a significant share of cancer deaths. Globally, it's estimated to cause around 5.5% of all cancer deaths, which is a pretty substantial burden for something that's still widely seen as a normal part of everyday life for a lot of people. And the World Cancer Research Fund has identified alcohol use partially causes breast cancer, laryngeal cancer, sorry, yeah, breast cancer, laryngeal cancer, pancreatic cancer, oral cancers, liver cancer, esophageal cancer, and colorectal cancer. Good news is that there are policy tools that can help mitigate the effects of alcohol-caused cancer, one of which are cancer warning labels. We have some evidence from studies that we've done in the Yukon and Northwest Territories that when you put direct health warnings, such as cancer warning labels, right on the alcohol container, it can change consumers' behaviors. These labels have reduced per capita alcohol sales in those regions where the policy took place. I'll explain that a little bit later in a future slide. And then the second tool is minimum unit pricing, which means setting a base price per standard drink. So you wouldn't be able to sell strong alcohol for like super cheap. It's been used successfully in Scotland, Wales, and parts of Canada, and it's been shown to reduce overall consumption, especially among people at highest risk levels. So in our modeling study, we collected cancer incidence and mortality data from the Canadian Cancer Registry and separated that out by sex, age, province, and territory, and by cancer type. Then we gathered alcohol use data from the Canadian Community Health Survey to estimate the prevalence and frequency of alcohol use. Since folks tend to underreport the amount of alcohol they consume, we uplifted those estimates slightly by using the alcohol sales data by province and territory and spread that over each of the populations of interest. And yeah, so in terms of our methods, before we estimated the potential impact of those warning labels and minimum unit pricing, we first calculated how many cancer cases and deaths in Canada are currently directly caused by alcohol. To do that, we took the number of cancer cases and deaths and multiplied them by what's called the alcohol attributable fraction, the AAF. That fraction represents the proportion of cases we would expect not to occur if alcohol weren't being consumed based on population level alcohol use. These AAFs are calculated using what Amanda was mentioning earlier, that Adams authored. They're calculated using InterMAHP, which is the International Model of Alcohol Harms and Policies. And it's used to estimate the impact of alcohol harms on public health. Once we had the AAFs, we could estimate the baseline number of cancer incidents and mortalities. In other words, how much of Canada's cancer burden is already being driven by alcohol. Then we applied the different policy scenarios to see how that number could change. So here's what we found at those baseline estimates. In 2022, alcohol use caused an estimated 19,498 cancer cases and 3,866 cancer deaths in Canada. That means about 1 in 20 cancer deaths in this country in 2022 were caused by alcohol. This graph essentially shows the proportion of cancer mortalities that are caused by alcohol in red. So you'll notice for breast cancer, for example, even though the alcohol cause fraction is lower than some of those other cancer sites, because breast cancer is a more common type of cancer, there were still approximately 394 cancer mortalities caused by alcohol for breast cancer. You'll also notice the especially high alcohol cause fractions, like the esophageal cancer and those oral cavity and pharyngeal cancers. Yeah, these AAF proportions are a little bit higher than some of these other cancer sites. This baseline gives us a sense of just how much the cancer burden in Canada could be preventable through alcohol policy. It's also the foundation we use to model what would happen under different policy scenarios, which we'll get into next. We modeled 5 different alcohol policy scenarios. So 2 focused on pricing and 2 were focused on alcohol warning labels and a combined warning label approach. In this first scenario, it was a cancer warning label on alcohol containers, similarly to what's been now legislated in Ireland and what we tested in the Yukon. And scenario 2 was a multi-message rotating label. It's included like both, or sometimes a cancer warning label and a Canada's low risk drinking guidelines and standard drink information that I would just kind of rotate between. The changes in alcohol use that these cancer warning labels and multi-message rotating labels impacted came from that Yukon study that I was discussing. Basically, in that study, researchers attached labels to each bottle sold in Whitehorse, while a matched city in the Northwest Territories acted as the control site. The first phase in the study was a single bright yellow label that said, warning, alcohol can cause cancer. After 8 weeks, sales data showed a 2.3% drop in per capita alcohol sales for the labeled products compared with the control site. Then after a little bit of a pause, the team relaunched the study with a 3 label rotating between those ones that I mentioned, cancer warning label, low risk drinking guidelines, and standard drink information. And then over the next 6 months, combined sales for the labeled products fell by 6.6% relative to the control, which was almost like 3 times the effect that the first cancer warning label had. Qualitative surveys also during the study showed that awareness of alcohol cancer link jumped by roughly like 25 percentage points during the study. So then in scenarios 3 and 4 there, we looked at minimum unit pricing. So in scenario 3, we modeled a $1.75 minimum unit price per standard drink. And scenario 4, we modeled a $2 minimum unit price. Then in scenario 5, we combined both the $2 minimum unit price with a cancer warning label to estimate their potential impact on cancer deaths and incidence. And I think I have a few. Yeah, so here are a couple of the examples of the warning labels that were used. And then I think I will pass it over to Adam for these remaining slides.
Thanks so much, Keegan. So Keegan's done pretty much all of the heavy lifting. He's gone through the background and methodology, and now I just get to talk about findings and discussions. So thank you so much, Keegan, for doing that. Just on the, if you go back to the last slide, I just want to look at those labels for a minute. So these are the ones that were deployed in Yukon for the study up there. Just give a shout out to Kate Valance, who is here, I think, attending the webinar. And I know that she was one of the ones that physically went to Whitehorse and labeled alcohol bottles with those labels using a labeler. There's a famous photo of her and Aaron Hoban in CSER where they're labeling the bottles. So yeah, really amazing work. That study, the Northern Territories alcohol labeling study that kind of underpins some of the modeling work that we've done here. We wouldn't have been able to do the modeling work, of course, without the real world implementation of that labeling study. Yeah, if we go to the next slide. So into the results. So we're kind of theoretically deploying those 5 different policy scenarios that Keegan described on the last slide, and those will typically be along the top in the column headings. So scenario 1 being the cancer label, where a cancer label is put on alcohol containers. Then MMR is the multi-message rotating, the 3 different labels that take turns rotating around. So people are seeing different messages at different times. MUPs of $1.75 and $2. And then, like Keegan said, the combined scenario where we put together the cancer label and the higher minimum unit price of $2. So this slide that we're looking at is talking about the predicted or modeled alcohol use change or alcohol sales change upon the deployment of those 5 different policy scenarios. So the minuses are how much sales would decrease. And if we look at the cancer label, for example, in the total row, which is along the bottom, if we were to deploy a cancer label, in this case, all across Canada, we kind of modeled that the effect would be a 2.4% reduction in alcohol sales with confidence intervals below it. If we were to put forward a multi-message rotating label, a 6.6% decrease in alcohol use. Again, I'm in the total row, although it's the same for males and females. Now in the minimum unit price results, the $1.75 unit price, a bit lower, of course, than the $2 one. We might see, or we would be predicted to see a reduction of about 3.7% in alcohol sales. It wouldn't affect a lot of products at a level of $1.75. Most products already sell for more than $1.75 per standard drink. Not all, of course, but most. So only those products that are currently selling for less than $1.75 per standard drink would be affected. And then similarly, here moving over to the $2 one, that takes a bigger chunk. There's more products that are selling for less than $2 per standard drink. And so deploying an MUP of $2 raises the price of more products, and we get a larger decrease in sales. In the combined scenario, where governments decided to implement both an MUP of $2 and a cancer warning label, this is the largest predicted decrease of just under 11% in alcohol sales. So alcohol sales would go down for about 11%, by about 11%. For context, that's about the same amount that alcohol sales has already dropped from 2020 to 2023. So coming over, there's a bit of a kind of a moderate peak during COVID in the 2020 year, and then trying to do this the way that people would see it on their screens. But anyway, we're coming down off that peak, and now in the 2023 year, alcohol sales has dropped quite substantially, and it's the lowest recorded sales on record in terms of per capita standard drinks. So sales have been dropping, and policy scenarios like these would kind of reinforce those changes. We could go to the next slide, please, Keegan. So now the last slide was talking about the decrease in alcohol sales that would be predicted on those different policy scenarios. Here we pull the sales through to the changes in predicted harms. So predicted harms both in terms of cancer incidence, which is in the top panel of results, and cancer mortalities, which is in the bottom panel of results. Each of those is broken up by sex, female and male, and then we also have the total, which is the colored row, the kind of light orange row moving across the bottom. And again, the scenarios are along the top, moving from left to right. So yeah, if we look at, let's say, cancer incident cases in the total row, the cancer warning label would be, or we modeled it to be a predicted decrease of about 163 cancer incident cases. So 163 fewer cancer incidence cases would occur if the cancer warning label was deployed as a policy, and then kind of moving across, which people can read for themselves. Maybe I'll pick off the last result though and put in the rightmost policy for cancer incidence. It would be associated with a predicted 674 fewer cancer incidence cases, and now down into the cancer mortality panel, fewer 216 cancer deaths, with the percentages being in brackets. So those alcohol use decreases are predicted or modeled to be associated with these decreases in the cancer harms caused by alcohol use. We could go to the next slide, Keegan. We also looked at it by province and territory. I know there are some people internationally, so Canada is made up of 10 provinces, which are kind of along the south, if you could call it south. Well, it's south in Canadian terms anyway. And then across the north are 3 northern territories. So in total we have 13 jurisdictions. Here they're highlighted by province and territory, and the deeper green is a deeper reduction. So if we look at the kind of top right one in the incidence panel, where we're looking at the cancer label with an MUP of $2, we're seeing kind of deep green reductions in Yukon Territory, in British Columbia, and Alberta, Ontario, and Quebec, the kind of most populous provinces, coincidentally, because the depth of the reduction is based on a few things: how much alcohol is used in those provinces, and then also the distribution of the cancer incidence and mortality by cancer site. So quite deep reductions there. Similarly in mortality, although not as deep reductions, or the colors aren't as bright as in incidence, since these are all scaled between 0 being no change and -8, which is an 8% reduction in incidence and mortality, but still quite bright, or quite, maybe I'll say deep, the coloring in Quebec and BC and Yukon in the bottom right, whereas Ontario and Alberta, prairie provinces, are kind of in the middle range, probably about 4 or 5% reductions in terms of the cancer mortality that could be reduced. Go to the next slide, please, Keegan. And then the other piece that we brought into the puzzle for this study was we also wanted to look at how those policies would affect people in different socioeconomic groups. What we did to build up a socioeconomic position variable was we used household income. Household income comes in deciles, and we built that up by combining two beside each other into quintiles. So on the left of these panels, the socioeconomic position, there are 5 household income quintiles, going from kind of the lowest household income up to the highest household income. Similarly for the mortality panel, I'm gonna go to the next slide, actually, Keegan, which is a bit easier to kind of see. And here we again have it by socioeconomic position, where the socioeconomic positions are the bar colors. So along the bottom of those figures, the deepness of the purple isn't about the size of the reduction, it's about the socioeconomic position. So the lightest purple is the lowest household income quintile, up to the darkest purple is the highest household income quintile. If we look at, let's start with the right panel, so the mortality figures. If we look at the first two policy scenarios, moving from left to right around along the x-axis, the cancer warning label and the multi-message rotating label. In these, because of the distribution of cancer in the population by socioeconomic position, we actually get a larger reduction, given by the size of the bar, a larger reduction in the highest and higher socioeconomic position groups for deployments like labeling. But then when we look at the next two panels, the minimum unit price panels, those are reversed. So when we think about pricing implementations, these are much more equity oriented in that they impact people with lower income more than higher income. So you can see how that gradient, the two gradients are reversed in terms of the reduction. So in the MUP scenarios, people with lower income or people living in households with lower income are experiencing a greater reduction upon the deployment of those minimum unit price policies than are people that are living in households with higher income. In the combined scenario then, because it's kind of like mixing those two gradients together, we see the highest impact is actually in the second lowest household income quintile group, the second lightest purple bar. This is on the right-hand side of the mortality figure. Yeah, thanks, Keegan. And then we kind of go down from there. So there's similar in socioeconomic groups 1 and 3, kind of similar, and then it drops off with the highest people in the highest household income quintile experiencing the least benefit from that combined policy, where we kind of deploy both the minimum unit price and a cancer warning label. So these socioeconomic position findings I thought were really fascinating. Not necessarily something that we expected, or at least I wasn't really sure how it would break down when we did the modeling by socioeconomic position. So to see those findings for the pricing scenarios, at least, where people with the lowest means are getting the kind of reaping the largest benefit in terms of the cancer mortality reduction and cancer incidence reduction, I think that's an important result, excuse me, from this study. If we go to the next slide. Kind of reiterating in better words what I was just describing. So why focus on equity? Many, but maybe not all of us will know that alcohol harms follow a social gradient. And so lower income groups or lower socioeconomic position groups often suffer more harm despite consuming almost always less alcohol. So this is called, in the field, it's called the alcohol harms paradox. And people that have a lower socioeconomic position experience more harms from alcohol, even though they drink mostly less, like for the large extent, the people in those groups drink less than people in higher income groups. So that is an important result and something that probably we should try to address, possibly through policy. We also have a compounding effects here. So people in those groups are also often experiencing limited access to healthcare, possibly lower health literacy, and higher baseline risks. So kind of in general, we can think about this as as an average, not for every individual, but as a group average, the group lacks resilience or doesn't have as much resilience as people with higher income groups, or we could call this increased frailty. So those things kind of compound. And the bottom point now, our model kind of shows that the combined MUP and label policy narrow the gap. So the larger relative benefits were hitting those lower household income quintile groups, the bottom three groups by household income quintile. So that would kind of work to narrow the gap. And at least in alcohol-caused cancer harms, begin to address health inequalities. We move to the next slide. So just as a summary of findings and to reiterate and kind of bring into focus what was said throughout the presentation. So I'll just say again that the baseline burden for our study year, which was 2022, alcohol caused, it's 19,000, so it's just missing the one, 19,498 cancer incident cases and 3,866 deaths in Canada. So that's as it is. That's nothing to do with the modeling. That's just our estimate of the baseline in 2022. And then we deployed these 5 different hypothetical policy scenarios, found that the strongest policy scenario was the one that combined, I mean, this isn't really surprising because it's the highest price and then and it also has a warning label, but the strongest policy in terms of reducing cancer incidence and mortality that's caused by alcohol was the $2 minimum unit price in conjunction with the cancer warning label. And this would have, or we predict through modeling that this would have been associated with a cancer incidence reduction of 674 cases and 216 fewer alcohol-caused cancer deaths. The largest reductions by province were in Ontario, Quebec, and British Columbia. And in terms of the cancer sites, the cancer sites that were most responsive to the alcohol policies, or we could think about it as the most responsive to reductions in alcohol use or sales, were oral cavity cancer and pharyngeal cancer, with about a 13% reduction in the overall probably number of mortalities caused by that cancer site, and then also in breast cancer. So I mean, that particularly for breast cancer, because it's so common, the incidence rate is quite very high. That I think that's quite an important result there as well. Next slide, please, Keegan. Secondly, for the summary of findings, if we're looking at it through an equity lens, so in terms of this income gradient, the lowest quintile would experience the largest health-based gains with the focus on the health impact of what's happening when those policies are deployed. So in the kind of lower income quintiles, we're seeing 8 to 9% reductions in cases and also in deaths. And then in the highest quintile, it's about half as large, of 4% or 5% reductions. So there's quite a kind of a differential impact of the policy deployments on socioeconomic position groups, with the people in the lowest socioeconomic positions experiencing, as a group, of course, the largest gains. With sex differences, looking at men, the combined policy scenario would prevent or is modeled to prevent about 421 cancer cases and 159 deaths. And among women, 253 fewer cases, 57 fewer deaths. The percentages and brackets are fairly similar. So men men drink, consume a lot more alcohol, and so die more often from alcohol-caused cancer. The absolute reductions are larger for men. But in terms of the percentage, it's the percentage reduction, it's quite similar across those. The age profile, so the greatest absolute reductions in cancer burden are seen in the 55 to 74 age group. About 200 cases and 70 deaths would be averted. So interestingly, the absolute reductions are highest in the older ages, as we would expect, because there's much more cancer in the older ages than in the lower ages. But in terms of percent reductions or relative reductions, the relative reductions are higher in the lower age groups, the younger age groups, I should say. So I think the 25 to 34-year-olds have the largest relative reduction, and then it kind of goes down from there in terms of the relative reduction. So younger age groups experience kind of a proportionally larger benefit from alcohol policies. Probably, I mean, one thing would be that they have a lot of their potential drinking life left. So if anything is bringing down their use kind of modestly in the decades forward, that will kind of have a compounding effect on reducing their chances of developing cancer. So that would be one reason that these policies kind of have more bang for the buck for younger age groups as compared to older age groups. And I think last slide. Policy strength matters. So larger price increases, more comprehensive warning labels were tied. We projected that they would be tied to greater reductions in alcohol consumption and associated alcohol-caused cancer burden. In this study, we found what we're calling a kind of double win for health equity. So a policy that both cuts overall burden, which is important, and it's always important, but in today's environment, inflationary environment, maybe even more so. But it also narrows the alcohol harms gap, or the differential alcohol harms experienced by different socioeconomic groups. It narrows that gap. So the people of lower socioeconomic position, the amount that they're higher than those in higher socioeconomic position, that gap kind of narrows. So the differential wouldn't stay as large. And it could be seen to be feasible in Canada, of course, depending on kind of how we think about it, but minimum pricing frameworks do already exist. A minimum, basically a near perfect minimum unit price already exists in Manitoba. And like Keegan said in his background slides, in other countries like Scotland, Ireland, Wales, Northern Territory, I believe in Australia. And then there's proposed legislation, Bill S-245. I think that was the one from the fall, the bill before Parliament was dissolved before the last election. So there is a bill put forward for implementing federal warning labels, which would apply to all of Canada on alcohol containers. And I think okay, yeah, I was thinking that, Amanda. Northern Territory in Australia, I think, did away with their minimum unit price. That was kind of in the back of my mind when I was saying that. Thanks for putting that in the chat. I think the next slide just says thanks. And yeah, thanks to Keegan as well, my co-presenter, and happy to stay and discuss for as long as anyone would like.